discuss about the when to report HER2 ultra low, what clinical implications does it mean, and what are the protocols we used to follow in the histopathology lab. What is the log protocol? How should be the formalin and the pre-analytical factors regulate this HER2 status? And of course, the most important part, the quality control of the reporting. And then we have to be updated about the recent ASCO CAP guideline, and we must mention in the report that what the ASCO CAP is saying as far as the new HER2 classification is concerned. So to start with, I would like to start with the Destiny 04 trial. So it is the, you can say, like it's a renaissance as far as the HER2 status is concerned. So in Destiny 4 trial, it literally breaks the typical binary of HER2 low and sorry, it's not HER2 low, the HER2 positive and typical negative. In between, there is a third space. The Destiny trial has created a third space, which is neither a typical HER2 positive or not a typical negative, which is HER2 low. So this HER2 low has created a lot of influence in the clinical part. So as my previous speakers have described it, that in the Destiny 06 trial, which is after the Destiny 4 trial, the efficacy of the TDXD is studied in the hormone receptor positive, HER2 low and ultra low, and chemotherapy naive metastatic breast cancer patients as compared against the physician's choice with a single agent chemotherapy. So what we have seen is the previously 60 to 65% patients which were categorized as HER2 low, and the rest of the 35 patients which were typically reported as HER2 negative can now be divided as HER2 null and HER2 ultra low. So the all the discussions, the crux is when to call it as ultra low, when to call it as a low, because the change in the reporting pattern means a lot to the clinicians. So you can see in this second bracket, the right hand side, we have mentioned that these are the candidates for the TDXD or antibody drug conjugate. So now you understand that a single report can lead to lot of clinical significance. So with this knowledge, let us see the traditional HER2 reporting, and we have to know the latest reporting protocol. Now, in the traditional HER2 stratifications, we used to report like HER2 positive, HER2 negative, and the equivocal, followed by the FISH testing. Now, currently, what in the 2023, we came to know that yes, we have to report HER2 low or HER2 1 plus, which can be reported as HER2 low. In the evolving landscape, in the later part of the 2024 and 2025, we are a bit updated, and we are calling this 0 plus category, which is in between HER2 null and in between the 1 plus to null. This space is the HER2 ultra low. So in the traditional practice, HER2 low we used to say as defined as immunohistochemistry wise 1 plus on IHC or 2 plus with fish after the fish positivity. So HER2 ultra low expression is defined as where the less than 10% of the infiltrating cells, not the DCIS component, is showing incomplete and faint or weak membranous positivity. So now you can understand to report HER2 ultra low, one must spend time in the high power magnification. So in the majority of the hormone receptor positive and HER2 negative in metastatic breast carcinoma, where HER2 positivity we have seen approximately 20%, and the triple negative group stands for the 15%. So rest has been reported as HER2 negative. Again, we call it negative means 0 or HER2 null, 1 plus, which is now as low positive, or 2 plus fish negative. So this 65% was the target. So in this 65% group, you can see that this HER2 ultra low category with 0 plus with membranous staining stands about 20 to 25%. So out of 65%, this 25% came to be ultra low. And the rest of the patients where this is hormone receptor positive and HER2 low stands for 60 to 65%, and rest of the patients which are completely zero, we call it HER2 null. So, there are two big giants in the as far as the reporting standard is concerned. One is the ESMO, one is the ASCO cap. Now, both they have provided the guideline that if there is a bit amount of positivity in the HER2 reporting, one must categorize it as a either HER2 low or HER2 ultra low. Now, when to call it? If in a day-to-day practice, if a histopathologist is seeing that there is a faint membranous staining of less than 10%, which is a bit of arbitrary, I must say. There is no strict criteria of 10%. If it is less than 10%, then according to the previous classification 20818 guideline, it was reported as HER2 negative or HER2 zero. Now in ISMO 2023, they now call it HER2 0 plus or HER2 ultra low. And the incomplete staining with more than 10% of invasive tumor component, which was previously again reported as HER2 negative, now we say it as HER2 low in spite of fish negativity. This is more important, I think, that even if your fish test is negative and you are getting more than 10% of the tumor cell, you can report it still on your IC report, it is HER2 low. And of course, weak to moderate staining, which is more than 10%, moderate staining, of course, fish positivity. Previous guideline also it was HER2 positive, and in ISMO 2023 guideline, it was still reported as positive, and rest of the criteria remains the same. So now the role of pathologist or the histopathologist, the importance of the histopathology reporting has increased quite a bit, because examining the HER2-IHC slide according to the guideline or the scoring criteria has to be mentioned, and it has to be formulated within each of the histopathology lab who is reporting this HER2. Now, the examination, as I have said earlier, must be seen and one must spend time with 40x, especially when you are discriminating between 0 to 1 plus staining. And considering the second pathologist review when the results are close to 0 or 1, or that means whether you are dealing with a null or a 1 plus or 0 plus, that should be the threshold. I mean the 10% cutoff value. Of course there are inter-observer variations in between the reporting, but still one must consider a second pathologist in the same department. Using controls with a range of protein expression, including 1 plus, to help and ensure has an appropriate limit of detection, and careful attention of the pre-analytical conditions of the breast cancer tissue samples, which I will be covering later part of my discussions, play an immense role in both primary as well as the lymph nodal metastatic sites. Now come to the directly interpretation part of the HER2. Now in this I must mention that please, when you are using the Ventana platform or you the Roche diagnostics, we must buy 4B5 monoclonal antibody. So this is one of the important clone. Apart from that, you can also buy A0485, which is also available, but still I will prefer the 4B5 clone, which is usually available in the market, and you can easily apply into your histopathology lab. And there are in the CAP guideline, there are so many clones which they have recommended. Apart from that, any other clone is not accepted. Of course, if you are using Bondmax on Leica, you can use CB11. CB11 is the second most commonly available antibody clone, but in my lab I prefer 4B5. I use 4B5 regular basis, and they are typically optimized for HER2 positive breast cancers only. not in other scenarios where HER2 testings are done, like in the pancreatobiliary and in the genitourinary systems. In the endometrial carcinoma, there is no strict criteria that these clones should be used. But later on, I mean, the protocols are changing. They will come with some guideline where they will fix the clone. But right now, these are for the breast tumors only, and further optimization of the standalone antibodies may be required, and laboratories are responsible for this assessment. Now, you can easily see the circumferential and membranous staining that is complete. I must say it is intense, it is visible, it is conspicuous, and is covering more than 10% tumor cells. You must label it as HER2 3 plus, no other left and right. You must mention your clinician that I am getting 3 plus positivity. So then and there they will start chemotherapy against HER2. In 2 plus, pathologists play a very crucial role because you have to write at the bottom of your report that FISH testing is mandatory because weak to moderate staining, more than 10% cells are there. And this moderate word is extremely important. Moment you say it is moderate, it falls under category of 2 plus. If you say that is a incomplete and membranous staining, remember this word, it is membranous, it is not cytoplasmic blush. It is has to be incomplete and it has to be linear, membranous, and barely perceptible in more than 10% cells. You must label it as score 1 plus, which is according to the latest guideline is the low positive HER2, and it is the candidate of TDXD. And of course, no staining, approximately at least not even a single cell is positive, you must score it as HER2 0, and according to the latest guideline, you should label it as HER2 null. So, as we discuss further, we get to know that at least 12,000 receptors should be there to call it as a positive. So, if it is a less than 12,000 receptor, we call it as HER2 null. Now, difference between the staining pattern and between 0 and 1 plus, as I have said earlier, is very much subtle. So if you are getting 1 plus or low positive, you must check your slides in the 40x. If it is 2 plus you are getting, you have to cross check it under 10 to 20x. And if you are 3 plus, you are very confident, you can make your diagnosis under the scanner, or you might say low power or 4x. So this is the standard guideline, and this is how it looks like under the microscope. And this is the 40x magnification view. You can see maybe needed. This is maybe needed, or it is needed, at least I do, to call it as HER2 low or HER2 0 or 1 plus in the 40x when the discrimination is necessary. So I must say that identifying HER2 ultra low breast cancer is more challenging for the pathologist, because what I have seen in my lab, that outside blocks becomes difficult. It becomes a nightmare sometimes. If in outside block you are getting HER2 ultra low or HER2 low, you don't know the which protocol they have followed to fix the slides, to fix the specimen. The individual differences in the color perception is a major problem sometimes, and that is why the automations is coming. It will remove all the color perceptions and confusion with the potential cytoplasmic and non-specific training. But again, the automations also has some limitations. However, I will suggest the pathologists need to have accurately select the appropriate fields. So before you hand over the slide or the block to your technicians, you must mention that these is the area, or these are the areas where you are getting maximum cellularity. It also applies for the IHC as well as the FISH testing. And whenever you are getting a faint staining, please show the slide to your fellow colleagues and examine under 40x. It matters a lot to the patient, hence for the clinicians. Now, how to report? The next important questions, that how to report it. Now, the results and report may influence the clinician's decisions making. So the consistency of the data elements, improved completeness and accuracy and ease of reporting. And the template assists the pathologist in providing clinically relevant information when reporting biomarker tests results. However, all the labs in our country which I have seen, they do not follow the typical template pattern. Each lab and each hospital I have seen, they have their own protocols. But whatever be the protocol, one must mention that how long it was there in the formalin, or what I mean to say in short, the ASCO cap footnote has to be there. And the synoptic reporting is a process for specific pathological data, as we all know, in a structural format, as opposed to narrative style. Now nobody wants to read the lot of straight lines in your report. So make it synoptic so that easily readable, easily understandable to the clinicians, because a report is a communication between the two doctors, be it pathologists, be it clinicians. So it has to be understandable. And the CAP has published examples of reporting, like consideration of the Her2 pathology reporting, that how to select the slides and when to report, and the classification of the Her2 scoring. So we must visit the ASCO CAP guideline while reporting it in a standard histopathology lab. So the footnote must mention that patients with the breast cancer with HER2 IFC 3 plus and 2 plus may be eligible. This may be is important for several therapies that disrupt the HER2 signaling pathway. And invasive breast cancer tests which are HER2 negative are more specifically considered HER2 negative for protein overexpression or gene amplification, since non-overexpressed level of the HER2 protein may be present in these cases. So this is more important that the last line, the overexpression and gene amplification, since overexpressed levels of the HER2 protein may be present in these cases. And the patients with breast cancer that are HER2 1 plus and 2 plus with each non-amplified may be eligible for the treatment for the targeted and non-amplified levels of HER2 expression for cytotoxic drug delivery. So high HC0 results do not result in eligibility currently. So one must mention this report should be there. So these lines should be mentioned in the report. Now, according to the uh, test criteria, now the purpose is when to test. The expression of HER2, as you all know, is dynamic. So we have seen that in case of primary versus residual breast cancer, some portions of the HER2 ultra low or HER2 low has been reported in the residual breast cancer, approximately 14.8%. And on the other hand, another study in patients with the matched primary and recurrent stage 4 breast cancer samples found that 15% of the cases switched from HER2 0 to HER2 low, while 14% of the cases switched from HER2 low to HER2 null. So therefore, the expression of HER2 is very much dynamic. And among patients with a primary HER2 negative, defined as 0, 1 plus or 2 plus and FIS negative tumor, the switching rate of HER2 status was higher. This is extremely important. So patients with a HER2 negative, their switching status of HER2 was higher in in hormone receptor positive and HER2 negative versus TNBC cases. So we must remember these things. And retesting of the HER2 expression in a metastatic setting is a key for expanding treatment opportunities in this. We never know. So in case of metastatic setting, one must do the retesting of the HER2, especially the HER2 when it has been done in some other lab or in some other hospitals. The metastatic site is extremely important. One must be aware that you might get HER2 low or HER2 ultra low. So there are several factors also that suggest that importance of the retesting. One of the important factors is the if the primary tumor is heterogeneous. Yes, it can be for the receptor expressions, which the nature of the HER2 is also heterogeneous. And when the receptor status of the primary tumor is unknown, and if the metastatic evolution of the metastatic clone is unusual as compared with the tumor characters, which also might happen. And of course, the new therapies, if available, and the initial test was performed more than 10 years, so one must ignore if it is done more than 10 years. And of course, the infrastructural support or the financial supports are there. So these are the factors which can regulate the retesting of the HER2 in a metastatic setting. So as per DB06 trial, in the subset analysis, efficacy of the DDXG and the HER2, similarly irrespective of the tumor locations and the sample collection types. So if we see the tumor which are in the primary site, there are a number of, out of 93, there are 55 patients which are from the primary, and out of 343, there are 214 was from the metastatic site, and at least one IHC report with discrete IHC scores and percentage of the cells stained is required in case of metastatic setting. So I will go directly to the prevalence of the HER2 ultralow among patients with advanced breast cancer with historical IHC 0 status. So these are the pre-analytical factors. It includes the sample collections, fixations, storage, and the ends in reporting and the interpretation. So there are multiple sources of variations in the IHC interpretation. It starts with the pre-analytical, analytical, and the post-analytical factors. So standardization of the practice, quality assurance program, and automation have potentials to be of significant impact. So these are the standard SOP which I follow in our lab also. This is the sample collections, sample processing, and transport, storage, followed by the IHCs. And the importance of the ensuring the cold ischemia time is also important. It has to be 30 minutes to 2 hours. So cold ischemia times and fixation influences a lot. Fixation time in 10% of neutral buffered formalin should be between 6 and 72 hours, and sections should be 5 to 10 micrometer thick and cut within 6 weeks of the HER2 staining. So old slide should be discarded, and the cold ischemic time should be as short as possible, ideally within 1 hour, or you can say 30 minutes to 2 hours. And impact of the storage of the sections of the HER2 testing also influences a lot. The signal intensity decreases over time, and the sections which are stored more than 6 weeks should not be used for HER2 testing. So you can see here the freshly cut sections at less than 1 week and old sections of more than 6. You can easily see the difference between the quality of the staining. And similarly, the freshly cut sections of less than 1 week and old sections at more than 6 months, you can see the same case, you can see the difference. So why I am saying this, because the interpretation directly correlates with the prognosis and the therapy. So you might report a HER2 3 plus case to HER2 1 plus or 0 plus. So the old cases should be disregarded, old biopsy should be disregarded. More than 6 months old, you can go for a fresh biopsy and a fresh IHC testing, because the signal intensity varies and it is rapidly decreases if it is stored more than 6 weeks. So the key takeaway is that getting updated information from the ASCO cap is extremely important. You must know when to call it HER2 low and HER2 ultra low, and the definition of the low and ultra low should be correlated with the standard histopathology microphotographs which are there in various websites. In the AstraZeneca also they have, in the Ventana, in the Roche website also they have published quite a few good photographs of standard photographs. One can take help from that. And in order to provide benefit of targeted therapy, the updated guideline has to be strictly followed. The footnotes need to be mentioned, and the percentage of stained cells which you are taking as a positive has to be mentioned in the first bracket. And the role of the second pathologist, where there is a diversity in the staining pattern is there, has to be considered. And pre-analytical factors need to be kept in mind. And the template footnote reporting system or the synaptic reporting system must be implemented. So thank you very much.